IPE for me is about many hands making the work light. I do believe that getting those hands to work around the same thing requires a lot more energies, and I think that that's what often prevents us from working in that way. But once the system's up and running, it does make things a lot easier for you and does free up a lot more of that time.
So at the time I was coordinating the IPC program, which is Integrated Primary Care, in the Department of Family Medicine, and we wanted to see students interacting with colleagues in the primary healthcare setting. So that would be community health centers, basic primary healthcare clinics, for them to understand it was not only the doctor's role in the management of a patient, and if you wanted to give holistic care to any individual, especially in a primary healthcare setting, you needed to include other health professionals. And so we designed this program for them to follow a patient and see who interacted with that patient, what that allied professional's role was, what they learnt from that allied health professional or professionals, and see how that impacted the way in which they would manage patients in the future and how they would include those professionals going forward. So while they were following their patient, we said, go and see what the OTs are doing, how the OTs are helping, people with rheumatoid arthritis or whatever else. And like I say, a lot of them really valued that input because they had no idea what allied health professionals were doing. And now with our GEMP 1 program, which is the junior medical students, the third year medical students, we have something called nursing visits, where they are specifically focused on understanding the role of the nurse in treating the patients. And we, part of the briefing is that you don't follow the doctor, you don't follow the interns, you follow the nurse. You see what they do, how they talk to the patients and interact, and see what their role is. So that happens in their third year medical program. And then also part of that is their CCE visits, which is in the community. They follow community health workers.
The resources and just how those staff are deployed to different facilities means that you're often not exposed to a bigger team, even if you would want to. And I think that they realize that as a value when they are able to work with a bigger sense of this team to deliver the best health outcomes. They then somehow get it, and their roles become a lot more amplified. And so we're needing to look at how we can possibly have them learn together at more opportunities. See how some of our lectures, our group activities are somehow collapsed and linked up.
That's what I would want the students to understand going forward, that it's not one clinician or one allied health professional that's responsible overall. It's about educating the patient about getting the best for them.
It absolutely is aligning our efforts a lot more strategically than it has in the past. Because I think with the funding to do the work, there's a little bit more direction that's given, because that direction and support doesn't often come from the institution itself. So it's, for example, with the perception study, it's really nice that the perceptions are going to be looked at across those partners in the same way, using the same tools. I don't think that we would have pursued that kind of same study had it not been supported in that way. With the example of Trinity Clinic, I mean, that is such a good opportunity that at this point we should have already replicated for the university and for the faculty to really say that this is about us bringing together the learning opportunities for students, but also the practice of delivering healthcare in this kind of way.
But what we do is we refer to each stage. So I've even offered it to you, Jade, for the chiropractors and for the optometrists, and we've even offered the tourism and hospitality and food in division if they would like to come and contribute to the feeding scheme. So this is consulting room 1 and a food drive. So we get a special food package because it provides all the nutrients that they're lacking, the vitamins, the MCT oils, all of that. But the church offers the normal food, feeding kitchen. We have, in fact, we double up in December. So we try to have it at night as well. This outside when we're conducting screening and testing for pharmacists. In terms of mental health, that's what I was talking about with the rehab facility and things like that. We're looking towards incorporating a social work. So from their department to start off, these are, if the doctor needs to collect
A urine
sample. We've got blood tubes, we collect blood. And then the doctor will phone me during the rest of the week and say that, listen, we have this patient. We contact the church tracks the patient down, and then we refer them.
Okay. How many patients do you see on a Monday evening?
Excess of 120.
Excess of 120.
15 years ago, one of the medical students who lived in our residence said she wanted to come and do something with her friends for the homeless. It started, med school got involved, and then eventually it became accredited as a proper society, and then they got professors involved, and they could then begin to have a doctor to oversee the work of the students. They got donations to set up the consulting rooms. A few years later, they then were able to get the pharmacy accredited to community pharmacy. And up until then, the medical students had been giving out drugs, but obviously not anything above Schedule 3. We then basically did training of medical students and counseling. Within a year or two, that began to involve pharmacists.
Okay.
So there's certainly scope for kind of social work to get involved, mental health, job creation would be great. Yeah.
Job creation, okay.
Reignite
Like
that
that.
passion for kind of community medicine, working with kind of the poor and homeless.
Yeah.
That's one thing. We have to start with medical students, pharmacist students, just to reignite that. And then you can actually draw in all the other disciplines.
The development of the students there is that they must get involved in the community outreach programs. Otherwise, they don't get to stay at Trinity House.
Okay.
Yes, because it's not a boarding house, it's a community center where we develop and teach them on how to work with, yeah, exactly.
We have registered pharmacy and clinical, our own university dispensing site as well as health clinic.
And is that an ideal for other medical schools to follow?
It is, and we've had several of them come and visit with the Pharmacy Council.
Okay.
So we got another visit upcoming in August. And what happens is they look at the thing and they at the site and they're amazed and then they want to go back and implement it at their own. It's easily reproducible, easily applicable, and it'll definitely be a good thing to do.
Pharmacist, nurse, dietitian, occupational therapist, physio, speech doctor, clinical associate, and social worker. Think through about how much more you need to know or get to know about the other professions. For the roles and those answers, that we have a sense of who got them wrong. It is an opportunity to discuss and to reach the clarification that's needed. So 3 kind of brains came together to think and thrash it out. Definitely made it easier because we could direct, give me 3 questions around this, give me, what do you know about this profession, you know? And that's the kind of way in which we should be mapping out our teaching interactions as well.